get to do things that make a direct difference. So with that in mind, I'll start the talk. I don't have any financial disclosures related to this talk that I'm going to give. I work primarily with Medtronic in town here as far as deep brain stimulators go. They use a whole variety of companies across the spectrum of neurosurgery. I'm fully trained with framed systems as well as frameless. We'll talk about that, but I choose, because I believe it, that frameless systems are better and they're the way that things are moving, and that's the way I would have it done if I needed it. So the surgical experience of getting a deep brain stimulator has many different parts. The first part is the part that Dr. Fargman, and Dr. Mari, Dr. Landers, everybody is involved in, and that comes well before I exist. That is making the proper diagnosis. No proper diagnosis, you can do an operation, but it's not going to work. So I don't even want to know you before you're properly diagnosed. The decision on your surgeon, that's a really critical decision. Getting clearance. People ask me all the time about, how come it takes so long to get this done? Well, it's a chronic problem. It's a completely elective operation. You want to be as optimized and properly thought through, diagnosed, imaged, cleared, evaluated, and assessed in every way possible prior to having someone like me poke your brain. Planning. That's the planning stages of how to, where, when, etc. Then the surgery, typically for insurance reasons more than anything else, has two stages. Stage 1 and stage 2, which we'll talk about, and then following. So, making the diagnosis, again, I am not a neurologist, movement disorder neurologist, I'm a neurosurgeon. So I know this much about what Dr. Farman does, and he knows this much about what I do. Maybe you can do this.
Overlap a little.
But he can't do what I can, and I can't do what he does. So we have to work symbiotically to make sure that we can do the right thing for you. So my one slide on diagnostics here is that Parkinson's and essential tremor are the most common tremor disorders. There's a lot of different ways that I don't necessarily focus on, but which I send people to neurologists for, even send them to specialty neurologists after their primary neurologist sends them to me. But it's making the right diagnosis, as I said. So which body parts are involved? What positions initiate tremors? What conditions do the tremors happen? The frequency of their tremors, and on and on. Do they have bradykinesia, slowness of movement? Do they have rigidity of their movements? Is there postural instability? Is there spasticity? Are there other things? So an 8 to 12 kilohertz, 8 to 12 hertz action tremor of the upper extremity that's relieved by some alcohol is, correct me if I'm wrong, Dr. Farman, that's usually in the essential tremor category. I'm not making the diagnosis, but that's kind of classic. Somebody who's got pill rolling tremor with slowness of movement and rigidity is typically Parkinsonian. So again, the reason I care about those things and that I do the assessment, as well as getting the assessment from the neurologist, is because I have to choose where to put the leads. And if I choose the right patient but the wrong target, you don't get better. If I choose the wrong target or the wrong patient and the right target, you don't get better. So it's a simple game that you just have to get right. The neurologist typically is making the diagnosis and maintains the patient with medications before and after. A lot of the time, primary care physicians are the ones who are saying, you got a tremor. Maybe you should see a neurologist, or I even have referrals from neurosurgeons. I've even had referrals from other neurosurgeons who know that I put in deep brain stimulators, to send them to me, and I'm like, you need to get them sent to a neurologist. A lot of the time I will do consults on people, say for neck pain or back pain, in the hospital or in the office, and they're sitting there shaking like this, and I'm like, you need a neurologist. So again, a lot of people see it, and then we have to send them to the right people to properly make the diagnosis, and then they can come back. Not sure what. There. So this is a patient of mine, this guy named Ray. He's a wonderful man who came in. This is him before he had his procedure. This is actually on the day of his procedure, and he's really doing really well now. So critical considerations, making the diagnosis, again, not as the neurologist, but as the one taking responsibility for putting these things in, is to not make the wrong diagnosis. So if somebody has a lot of falls early in their disease, a lot of people who have tremors but have a poor response to levodopa or cinnamon, if they have a symmetry, meaning the right and left side are equal in their tremor at the time of onset, if it's a rapidly progressive condition, no tremor at all, if they have bladder and bowel incontinence, if they're symptomatic with orthostatic hypotension or low blood pressure when they stand up, if they have a lot of cognitive dysfunction or hallucinations, those are all things that are probably not Parkinson's disease or essential tremor. And so they're going back to neurology to get worked up and make the proper diagnosis before any treatment from me might be considered. So you have to rule out things like multisystem atrophy, progressive supranuclear palsy, corticobasal order degeneration, Lewy body dementia, and a host of other things that I've long since forgotten. So what are the appropriate treatment options for you as patients now, in the future, and coming down the line, much farther down the future? Often neurologists and non-neurologists who see patients, I'm not talking about, again, Dr. Farben, who's a movement disorder neurologist, I'm talking about your general neurologist, might be reluctant to send patients for surgery, for any surgery, back surgery. My best friend's father is a great neurologist. He never thinks anyone needs surgery. People have a giant herniated disc and can't stand up, and they don't need surgery because he doesn't believe in surgery. That's fine. My best friend's father, I've known him since I was 5. It's a great, Passover dinner. Frequently, patients and their family members don't want to have surgery. As I said, people don't want to have their appendix out when it's ruptured. Oh, it's surgery. People come to me and they're dragging their foot and they have a herniated disc. And they'll know surgery? I don't know about that. Well, you can't go to a surgeon's office. So, that being said, the flip side of that is you can live with this now and it's going to get worse and maybe be permanent. Or you consider some safe, well thought through, highly successful operation and a short recovery time and have a much better life. So I go right back to the patient and their family. So deep brain stimulators, which is what I'm talking about today, they're highly successful devices. They're designed to treat symptoms of Parkinson's disease, essential tremor, dystonia, epilepsy in some cases. They're used for more than 25 years. There are, I tell this to my son all the time. I said, nothing in life is free. My son's the bad. And I say, nothing in life is easy. Basically, it's not anything worth it is not easy. The decision to consider and move forward with deep brain stimulators with an operation on your brain is not something to be taken lightly. It's serious. That's why it's the punchline of a lot of jokes. It's not brain surgery. This is. So not to be taken lightly. So treatment options. Denial, it's always a good one, right? It's the most common one. Medications and making accommodations, wheelchairs, walkers, family members not taking you out, never leaving your house, having someone feed you, peg tubes, feeding tubes, things like that. Those are accommodations that we have that can be made. It's your choice. Complicated medication therapies. I mean, we have great drugs now that, I don't even know the names of half of these medications that Dr. Farber put people on. I don't know what the hell is that. I got to look it up in my office because I'm not sure if it's a vitamin or something for cancer or something for Parkinson's disease. Okay, they didn't exist when I was in medical school. But they're great options. But they're not the end of the line. Combination of medical and surgical therapies. It's interesting what Dr. Poston was just talking about, transcranial stuff. Non-surgeons are always looking for non-surgical ways to do what surgeons do. I'm biased. So is he. Okay? I'm sure Dr. Farber would love, I keep picking on Aaron, but I love you. Most neurologists would love to never have to send a patient to a surgeon because they can just put a little strap-on gizmo on your, hook it up to your glasses and go, no more tremor. But it ain't happening, not anytime soon. I can't wait till that happens. So the combination of medical and surgical plus the interventional therapies might make things really much better. For instance, I put a DBS in you, Dr. Farber can put you on some medications. Dr. Post can strap this little headband on you, and you'll never shake another time in your life. Now you might, Siri might answer for you. Okay, I can't say for sure. So you have to just accept that you have one of these conditions. That it's kind of like diabetes. You can't think about it as disease. If you think about it as disease, you're always a patient. Anyone in here have diabetes? Hypertension? Heart disease? High cholesterol? Someone in here's got all this stuff, right? I can see you got gray hair and stuff. These are conditions. These are conditions that we all get if we're lucky enough to achieve too many years. All of us. Okay, so congratulations. Diabetes is a disease that if it gets out of control, takes your life. Hypertension, same thing. Heart disease, same thing. It's not cancer. These are diseases that you live with. So is Parkinson's disease. So is tremor. Here's treatment. Medications and surgery. Treatment to make it so you just live with it. Okay, it's like taking insulin. So you need to replace batteries. I want to have smoke detectors. Got to replace those batteries too. They're a pain in the ass, but you got to do it. So if you're going to consider surgery, talk a couple seconds about how long this stuff's been going on for. 1908. A couple of British guys in England, okay, that's where British guys come from, they came up with this model called the Horsley and Clark model for stereotactic localization on the human brain. They did a bunch of dog studies, did a bunch of monkey studies, never used the actual device on people. 39 years later, we still have instruments Dr. Horsley designed. He was a neurosurgeon. I still use one of them in surgery frequently. 100 years old. Not in stereotactic surgery, but it's a device called the Horsley. So the first human operations were 39 years later by Spiegel and Weisses, and they published on it. However many people, they were just lesioning, they were burning. Okay, but there was no device. They had the Horsley model, Horsley device. Deep brain stimulation is a reversible therapy, meaning you put it in, take it out. Now, once you have something in your brain, you might not want to have to go through another operation to take it out. But I can tell you, taking it out is really easy, really easy. I've had to take out a few of them that, not my patients, but other people who have gotten infected or had brain tumors that developed around them or other things, they had to come out. It's real easy to remove, a lot easier to put them in. DBS therapy plus medications provides over 5 hours extra on time, without the bradykinias and dyskinesias and rigidity that you have when you're on medications. 5 extra hours of normal a day, on average. DBS therapy improves Parkinson's disease-related quality of life by 20% at 6 months, compared with medications. Just at 6 months. If you ask people 2 years or 5 years later, they'll kill you if you try to take this out of their head. DBS improves tremor scores over 12 months in essential tremor. Okay, so again, and you get out a year, 2, 5, 10, makes bigger differences. So other things to consider when you're considering surgery, you're going to need an MRI someday. One of the companies, Medtronic, let's say it is true, has a completely MRI compatible system. The other two, no. They're conditional things, etc. But I'm a neurosurgeon. I order MRIs on people every day, having nothing to do with Parkinson's disease, nothing to do with tremor. It's for their backs, for their necks, or they might have a tumor someplace and they need something in their pancreas, so they get a MRCP or things like that. So MRI is rapidly becoming necessary. So if it's not MRI compatible, it's a problem. So when you're considering, if any of you consider getting a deep brain stimulator, you got to think about what you want. You need a pacemaker. You got a pacemaker. Some of the systems are not pacemaker compatible. I'm not talking about Dr. Poston's study, which is not a pacemaker compatible study. I'm talking about the device itself. So a surgical experience from DBS in this country is, and globally, for deep brain stimulators, not lesioning, not frames, is from the 80s. 1987 in France. 1993, we have this battery we put in the United States, FDA cleared. 1997, we have clearances, more stuff from the FDA. Basically, it's a pacemaker battery and pacemaker wires that are modified that go in the brain as opposed to into the heart. The components of the deep brain stimulator, any company, basically the following. There's wires, and there's a generator, some connectors, okay? Then there's a programmer, that's this blue thing that's based, the one that you see up there is based on a Palm Pilot technology, which I always laugh at because I had one when I was like in college or medical school, and then at least hook it up to an iPhone. And then the patient programmer. And there's a variety of these things, and again, depending on the company and the generation, the system that you have, there's all different ones, but they all work basically the same. So, who's a surgeon? Qualifications and credentials. Want them to be a doctor, or want them to be a neurosurgeon. An orthopedist can't do this, a neurologist can't do this. You have to have somebody who has experience and can show you and tell you about the outcomes of their procedures. I'm in town 2 years. I think I've done 6 or 8 primaries in town here. I've done, the last one before I came here was years before. Okay, I'm rapidly trying to grow my practice in this here. There are people, one guy in town that's done more than I have, does a lot. He's been here a long time, doing a lot of the business. What's nice about deep brain stimulator therapy, the surgery part, is it's really simple. The simplest components of the really bad surgeries that I do every day, where I make a little hole, just a 14 millimeter hole. I make 2 little incisions that are this big. The other guy goes from ear to ear. I don't like that. It goes my mom, it goes my head. I don't want that. That's me. That's the way I was trained to do it. The surgical techniques and tools. I like it. I like to do it with frameless. That means I'm not putting some big contraption on your head, and I'll show you in a second. The tools, whether it's the generation of the product, whether it is the company that they're using or they're offering. Again, this is a discussion with your surgeon to know what you're getting put in you. I don't care if it's for your brain or your spine surgery and they need to put in pedicle screws or a plate on your neck or a hip implant or anything else. You're entitled as the patient to know what you're getting if you care to. The location. Mari's not here anymore, so I can say this at will. I don't think anyone should have to go to Cleveland to get DBS. I'm sure that maybe there's someone in here. I'm sure someone earlier in the day there was somebody sitting in this room that had flown to Cleveland after a virtual consultation with their surgeon to have a deep brain stimulator put in. I do this. I guarantee you, they might do more of it at the Cleveland clinic. But then when they have complications, you're stuck here. I'd rather you and I go out on a few dates. Okay, see you in the office, talk about things, you understand, you look me in the eye. You know I'm responsible for your head. If you have a problem, come to me, call me, rather than have some resident or fellow in Cleveland doing your operation. I assure you that's what happens. And then they come back here and you got an infection, and guess what? Now I'm pissed off, and I'm going to say go back to Cleveland. You didn't like me in the first place? Not my responsibility. I don't really do that. I take care of some UCLA players too. Okay, but yes.
No, I said you should have been a comedian.
That's my nighttime job.
When you retire.
What's that?
When you retire.
When I retire?
You're in the right place at Biggs.
Yeah, I can do that. I can do that. So the location. I'm not talking about the location on your head, but that's also important. Make sure that we're going to put it in the right place in your head. As I said, make the wrong diagnosis and do the right procedure on the right patient. You're putting it in the wrong place. It's like, you know, you get a bullseye in the other guy's target. That's not going to score their goal. You don't want to do that. Insurance. That has really practical applications. It's not the right reason, but it is a reason that drives a lot of decisions. You know, it's not going to cost you anything because your insurance is paying for it. Medicare pays for this. Okay, and the supplementals pay for this 100%. But sometimes the insurance company that you have dictates where you have to have it done. So that makes a difference. The personality of your surgeon. You know, you get this, whatever. You know, and then your comfort level with that person. Again, sometimes I've long since thought, you know, give me the asshole with the best hands to do my operation. But if that guy's not an asshole, he's got the best hands, perfect. That's the way you should think about everything, every surgery that you have. Okay? Same thing with your medical problems. You want somebody to do the right thing for you. It's nice that they got a good personality, but ultimately you don't have to go home with them, you don't have to have a drink with them, you don't have to have dinner with them. Okay? But like I said, deep brain stimulators, this is a little bit of a date. You go on another one, you like it, good. Surgery options. So we have lots of questions that exist. Framed versus frameless. Awake versus asleep. Staged versus single step. Device selection, meaning the company that you're going to have. The surgical procedure are the options. Integrated planning to programming. That means is there one company that has the whole system, or you have to use a piece of this, a piece of that, a piece of that. The support of the OR, where you're having it done. You know, you might have had a terrible experience at Hospital X and say, no, I want to go to Hospital Y for my surgery. That's usually fine, but you got to consider all the other things. Is that operating room staff do a good job, but they can take good care of you for this procedure. So here's frames. These are the guy on the left. The left is my patient from a couple years ago. That's a Lexel frame. Now, how'd you like to have that on your head for a couple of hours? You know, he's happy, smiling. You know, he's wide awake. I put it on him while he was wide awake. Okay, numbed up the spots. Okay, and it gets screwed into your head. It's probably a weird sensation. But that's the Lexel. And then the bottom right is the Lexel arc frame. Again, designed in 1949, still in use today. The other one at the top there is called the CRW, the Cosman Roberts Wells, which is, I think, about 1965. Okay, so based on the Horsley Clark model. So it's some old stuff. I've used them both, and they work. But you got these contraptions on your head. I've gone to using this. You saw a picture of my patient Ray, and I'll show you a picture in a second about how the frameless works. But this is this little contraption, which is about as big as my hand, which basically is a little ring that gets screwed on when you're in twilight through these little incisions, basically stuck on the skull to let me navigate and do the surgery. At the end of the surgery, I pull them off, close up everything, and you barely even know I was there. And talking about integration of planning, if you look at the bottom right, there's the two targets that I picked. This is basically where on the outside, and it the computer helps me create a trajectory from the optimum point on the outside to the optimum spot on the inside of your brain in 3 dimensions. Again, I personally, without any bias, I use Medtronic for this because they have Medtronic navigation system, Medtronic software, Medtronic hardware, this plastic gizmo here, Medtronic leads and tools, and Medtronic generators, batteries, and then programming. Plus I get Louis, who I know is really good with patients. So it's soup to nuts, as opposed to some of the other systems, which are very good systems, but they don't have all those pieces. So for me, it simplifies my life that I only have one guy I gotta call in order to set up a case. And if there's a problem, I only gotta call one person, not like 3 or 4 or 5 different people. And it translates to the patients as well, because if there's a problem with the battery and it's one company and the lead is another company, not to mention it invalidates the warranty on the system, it's not going to function as normally. You got to stick with your one system. Clearance, as I said before, there are reasons that this takes 3 months, 2 months, 5 months in some cases to get these to get lined up. If you're referred to me, I'm happy to get you in. I'll get you in real fast into the office. Then I've got to explain all this to you. You've got to understand. You've got to say, I'm going to think about it. I'm going to talk to my family. Unless Dr. Farman has sent you and said, you need DBS. Okay? Which sometimes he does. Because he knows who's going to get better with DBS. Probably better than I do. And so he'll send you in. But then, because you have diabetes and hypertension and heart disease, and you're on Lipitor, okay, and you have a bunch of other stuff, not to mention your aches and pains, you got to get cleared. The clearances are not just by the neurologist who sent you in. If it's a neurologist who works in the community in, like, you know, somewhere in Lake Havasu, who is a neurologist, I need you to see an expert. So I send you to Dr. Farman. Dr. Farman is going to say, yes, it's a good candidate, or no, it's not. And if you're a good candidate, it's real simple for him to send you back here. He might tune up your medications for the meantime, but great, it's an easy one. But you still got to see the cardiologist and your internist and anyone else that is important. I put a couple of the other specialists down here. There could be a handful. So once you get your clearance, which is really in your hands, to go to the cardiologist and your internist, and if they say you got to get an echocardiogram or a stress test or one of those things, that's for your health, not for mine. That's so you don't die. To make sure that it's good. Again, this is a chronic problem. It's not something that you need to die for an elective procedure. So if it means that you need optimization, they gotta add some, some blood pressure medication or something like that. Or I've had people who came in and they were short of breath, and I sent them, they ended up getting a heart cath and then a bypass. Now they're coming back, now they can have their DBS. But it was that big a deal. Planning for surgery includes a variety of things. The surgeon visit, not to mention the neurologist visit, getting the proper imaging, preoperative imaging. So we get a preoperative MRI. We get I have to look at it, you have to make plans, where are the targets, what are the general trajectories for these things, make sure it's a good quality study that goes into the computer system that we can work with it. We have to figure out which hospital, based on your insurance, based on your experiences and wants. Close to home or far away? I'm a big fan of close to home when you have quality. Planning your course. Some people say, oh, I'm going to have brain surgery. I'm going to need my kids to come in and take care of me. Or I'm going to have somebody look after my dog or my cat for a day or two. Or you just want to make sure that you have someone there. Some people live alone. Some people have, want to make sure that they have things that are social. Great. Planning. Arrangements, I always tell people to make arrangements for the whole month of their surgery. A little bit before, a little bit after. How you can get to the hospital, how you can get home from the hospital. Someone's going to make sure that you eat after surgery. Not the day of, but after. You got nurses at the hospital, okay? But you're going home one day after surgery. It's that straightforward procedure. And then managing your medications. Again, you need to make sure that all of your blood pressure and diabetes medicines plus your neurologic medications are stable. So this is a stage 1 procedure where we implant the leads. So this is another patient of mine came in, he's smiling. I just put those little markers in his head, right? Those are 5 little screws. Okay, he'd had no drugs other than some lidocaine at the incision sites. Okay, it doesn't hurt. Okay, so that's something that a lot of people freak out about. Oh, it's going to hurt. I'm going to be awake. It's going to hurt. He's smiling. This is literally 2 minutes after I just put those 5 little screws in his head. Okay, I'm generous with lidocaine, so it doesn't hurt. That's the worst part, is getting poked with a needle. So stage 1, you get to the hospital early. We like to do that at the hospital. Okay, we start early so we can go home. You have to do your introductions, get your consent. Beyond what we do in the office, there's the hospital stuff. We put the bone fiducials, which you just saw, that are placed by the surgeon. Some surgeons do this in the office a week before. I don't like that. I don't think it's necessary. You got enough stress in your life. You don't need to come in and then walk out with like a hairnet and a bunch of screws sticking out of your head. But some people do, and there's nothing wrong with that. You'll come to the hospital and you get a preoperative CT once I put the fiducials in your head. Fiducials are little markers. Then you go to the operating room for the procedure. You get some drugs, okay? The anesthesiologist is looking at you the whole time. You get taken care of. We put you out for the beginning of the surgery, making incisions and all that stuff, so you're comfortable. Most people don't have any recollection of that part. And that's the stress part, right? Getting an incision on it. Afterwards, oh, the worst part I forgot to say, for a lot of people, particularly women, is, and it doesn't matter who does it, shave your head. You can shave your head beforehand. A lot of men, they don't mind. Even you would have to shave your head, okay? It's all right. Hair grows back, brain doesn't. So you're in twilight anesthesia for the beginning part, and then we actually wake you up and have you move and do things, simple things that are specific to you, that we've tested you before surgery, in surgery, and after surgery. Write your name or sign your name. Screw in light bulbs. If you're a carpenter or an electrician, sometimes screw in the screw, right? Hold this instrument, hold that, do this, do that. depending on you. Again, that's those first questions we get when we're on our first date. The hospital time. So you got to get there early on the day of surgery. It's a long day for everybody involved. You, family, me, the nurses, okay? Don't plan anything afterwards. You're going to be tired, okay? The family has dinner. You go home and sleep it off. Or you're going to stay in the hospital overnight, but you're going to sleep it off. And you go home the next day, and you're going to feel like you just had brain surgery, okay? You're going to be tired. You get a CT done immediately after the leads are placed. The CT is to confirm that what the plan was matches what actually happened. If there's anything that's different or wrong and you're not perfect, we'll take you back and fix it. But that doesn't happen because it's a plan. It's very specific. You'll get a CT in the morning, again, to make sure there's no complications, no subdural hematoma that's happened, no hemorrhage at the site of puncture or at the site where the leads are. Then you go home. I had a problem with the first couple patients that I did in town here because the physical therapist came to look at the patients and they said, well, they have a hard time walking. It's like, well, they had a hard time walking before they got here. They use a wheelchair, for God's sakes. Okay? That's because the stimulator after stage 1 is not turned on. It's not turned on. You have something called the lesioning effect, which sometimes causes you to be better right away. Not fixed, just transiently over days to weeks. You're better than you were before you came in. Doesn't mean you're getting up and walking and having no shakes or tremors or rigidity, but you're better. Stage 2. So we're going to implant the generator, which is the battery, and connect the leads. It's a very easy operation. It's outpatient. Surgery takes 20 minutes. You're fully asleep, so you have to worry about being awake for that part. It's basically putting in a pacemaker. Does anyone in here have a pacemaker? For anything? Anyone's spouse? Okay. Anyone's spouse have a pacemaker? When you had yours, were you awake or asleep during the procedure?
Asleep.
Asleep, like intubated? Okay. Sometimes people get intubated for that, sometimes they don't. It's really choice. You get sedation, so it's not a freak out kind of moment. You decide which side you'd like to have the battery put in. Okay? Some people, I actually swear to God, had a patient say he was right-handed, he said he wanted the battery on the left side so he could shoot his rifle. Like, this is a Parkinson's patient who wants to shoot things. I can honestly say the next time someone says that, I'm going to put it right here. So you decide before the surgery which side you want it on. Some people, they're left-handed and they just want it on the right side, or they want it on the left side. You know, it totally doesn't matter to me. You get a 2-inch chest incision right behind, on the chest, a little centimeter incision right up here. They're both small and you barely see them. You see the battery sticking out here. You go home, but the stimulator's still not on. That part, that excitement, is saved for your neurologist a couple weeks later. Why? Because everything needs to scar in a certain period of time before the leads get their electricity run through them. And then discharge. So certain things between the stage 1 and stage 2. Perioperative antibiotics. I hate infections, okay? In this town in particular, or any desert location, it's dry. Skin doesn't heal quite the same as it does like in the Midwest or in Miami, okay? Because it's so dry. So the wounds will not heal as quickly or as well. So we have to do things like keep them covered or keep them moist, but also I put everybody on prophylactic perioperative antibiotics. I put you on vitamins starting a week or 2 before the surgery and for 3 to 6 months after surgery. You can take them for the rest of your life if you want, they'll just be healthy. You won't need a dressing per se, you'll have glue over the wound here. You'll have the blue over the wounds here as well. You'll follow up with your neurologist a couple weeks after the second surgery, and they get the excitement of turning it on. Okay, Louis always calls me or comes in the office and tells me how great, Mrs. Johnson or Mr. Jackson did. Okay, when they turn it on, how happy they are. That's always the situation. And then I'll see you about 3 to 4 weeks after, usually after your second stage, so I can check all your wounds and make sure everything's okay. I personally use all absorbable stitches, so technically you don't ever have to see me again. Stitches are going to fall out, they'll be fine. I like to see it because I want to make sure that everything's going well, your wounds look good, but I want to see how well you're doing. And then you work with your neurologist to optimize continually how you're doing and to continue to minimize or optimize your medications, and then they tell you when you need to get a battery replacement. So battery changes, this is the smoke detector effect, okay? Depending on what your settings are, you're going to have to replace your batteries either frequently or not so frequently. If you have very high settings, then you have to replace them more frequently. You have one generator. The new generation of these deep brain stimulators, there's one generator for 2 leads. Okay, so both sides through one. I've had one situation where it was infected over here, not one that I put in, but it came in, it was eroding through the skin, and I had to go up over the top of his head to the other side so that there was no problem. Okay, but in general, you get one battery on the chest, wherever you like it, and it's about a 2-inch incision. We use that repeatedly. These batteries can last supposedly 5 to 6 years. I've yet to see that. I don't know what's the longest that you've ever seen.
We have recharged for the last 15 years when we really put it in officially. So 3 to 5 years is what we tell people. We never want to talk in absolutes because they're batteries.
Yeah. So again, based on what the settings are, you have to change them more frequently. Your rep and your neurologist will tell you when you need them changed, what your 30-day or 90-day or 120-day window is to change out the batteries. I'm happy to replace batteries that I've put in, batteries that I haven't. Just change the battery. It takes about 10-15 minutes. It's a real easy procedure. You come in, you go home. Okay. And the future batteries that you get put in, well, if you stay in your lane. If you get Medtronic, you go with Medtronic. If you get St. Jude, you go with St. Jude. If you get Boston, you get Boston. You don't mix apples and oranges because they don't work the same. Even though the companies will say, well, yeah, well, no. So this is sort of what I think about getting older, and what they think too. Thank you very much.